Good evening, everyone, and welcome to Live with Mei Sze, a podcast centered on health and wellness. For those of you who have been tuning in since the end of last year, the past few episodes, it's good to see you all in 2025, a brand new year. And this year, I promise to be more consistent with the show, at least a minimum of once a month, if not once every 2 weeks. You know where to find all the posters to tell you when it will be. It usually happens 8:30 p.m. on a Thursday. Well, for those of you who don't know much about Talking Life with Mei Sze, like I mentioned, we talk a lot about health, wellness, and the past few episodes we talked about various types of cancers. And today's topic is on stomach cancer, a new hope. Now, for those of you who feel you resonate with the topic, or you have friends, family, loved ones who were touched by stomach cancer, you want people to know about it, please share this session right now, because as you all may know, at the end of the session, we're going to take questions from all of you live. We want to hear from you. We want you to put in your questions because then we can try to answer as many as possible. And more importantly, we want to raise awareness about stomach/gastric cancer. So a little bit about research, or rather facts about stomach cancer. Did you know that stomach cancer is one of the top 10 cancers in Malaysia? Well, for many of you who do not know, many actually present at later stages. And research has actually found that the 5-year full survival rate is actually higher than 93.6% if you present at earlier stages. And if you present at later stages, it's less than 20%. Now, the key here is early diagnosis and timely treatment clearly saves lives. So this is a very important fact. The number in terms of differences is very high, above 93.6% and less than 20% for those who present at later stages for 5-year survival rate. Surgery is the primary treatment for people who present at earlier stages, stage 1 and 2, and chemotherapy is usually not required. But if the disease progresses to the 3rd stage and beyond, a combination of surgery and chemotherapy will be conducted depending on the patient's condition. But however, this day and age, there are so many more advanced or developed treatments, and we are going to discuss that today. We are actually here to talk about it. We want to talk about the new hope available for all of you. Those of you who have stomach cancer now, or those of you who have relatives who have stomach cancer or had before. So remember, share this live right now with your friends, family, get them to tune in, get them to ask questions. That's what we want. We want to raise awareness. We want to reduce the 5-year survival rate. We want to increase the 5-year survival rate because it's higher than 93.6% if you present at earlier stages. So today I'm joined by 2 honored doctors. They're very kind to join the show. We have Dr. Ramesh, who is an upper gastrointestinal surgeon with Sanjil Medical. And we also have Dr. Jensen, who is a clinical oncologist with Curie Oncology with a special interest in gastrointestinal. So both of them have interests and specialize in gastrointestinal, and we are going to talk about stomach/gastric cancer. So let me dive straight into the questions. But for those of you who have questions, remember to put them in right now because we want to hear from you. So start putting in your questions. I'll start with Dr. Ramesh. Which parts do gastric cancer encompass in the human body?
Right. So we have an esophagus where we swallow, right? And that food goes down into the stomach. So that's the main area where cancer actually presents in the stomach cancer.
So the esophagus and the stomach area.
Yeah, but when you talk about gastric cancer, it's just only stomach. It doesn't involve esophagus or other organs. Yeah.
Okay, so any one of you can take this. How do we check for gastric cancer, and at what age should people start?
Oh, okay. So now, the interesting part is all of us have this thing called stomach bloating, or when we eat food, we feel very full, right? So these are actually some of the symptoms which may present in patients with gastric cancer. So how do you detect this? It's something very simple. The moment you have these kind of symptoms, we would suggest get an endoscopy done right? A simple camera, put it into your stomach and have a look inside. So that's the best way to actually detect early gastric cancers.
So I know this is out of topic, but this is at the top of my head. Many people have bloating, even
Exactly.
myself. So, and I'm sure many of you have asked me before. I have tons of DMs all the time when after I shared my story. How do I check for that time colorectal cancer? I have bloating all the time. My stomach always feels full. I think these two symptoms are very common. So, then how do we know?
Right. Okay. So if you have recurrent symptoms, right, you keep going to your family doctor, taking medication, and it doesn't get better, so then it needs to be further investigated. So that's when you go. So you don't have, the moment you have bloating, you don't have to get the endoscopy done, right? So if you have recurrent symptoms, then I think that's the best time to go and get it done.
Okay. So if you have recurrent symptoms, I think that's the key word for many of you who are wondering of bloating, you can get it checked. So that is the most common symptom that you have seen in gastric cancer
Yes.
patients? Bloating?
Yeah, bloating or feeling of fullness the moment you eat. Late symptoms, when you start vomiting out blood or you can't eat, so those actually considered late symptoms.
Okay.
Right.
What about you, Dr. Jensen?
Yeah, if I may add, I think in Malaysia, when we talk about gastric cancers, is there some form of screening programs and all that? I think we don't really have that kind of program being applied on. It's all about, a lot of time is about patients coming with certain symptoms that is related to the indigestion, just like what Dr. Mash has spoken. So the only way I will see is that sometimes screening happens when it depends on the cancer prevalence in the country. So if you look at the gastric cancers, like what Mei Sze was saying, that it was top 10. The last remembered was that from the National Cancer Registry, it was at the number 10. Sometimes when a screening program is being developed, it also depends on the cancer, how prevalent it is. So what I do know is that in Malaysia, we do have a colonoscopy screening program. So what I do see in my clinical practice is that I do notice that when someone goes for colonoscopy, so the current recommendation for colonoscopy is at the age of 45. So endoscopy, upper endoscopy and colonoscopy comes together as a package. So I suppose that if everybody is aware of having themselves checked for colorectal cancer screening at the age of 45, average rich group, then I would say that they also do get the upper endoscopy, and that sort of able to detect early when someone do not present with any symptoms. Yeah. So when that happens, then you get a much earlier stage of detection, and the treatments are rather much easier, and the intent is to cure for the patient.
I like the word cure. I think
Yeah.
curative is very important. And I believe you mentioned indigestion. So what does indigestion mean? Maybe you can break that down for many of us who don't know. We talk about indigestion a lot, but we don't really know what it means.
Yeah. So if I may, often not in my clinical practice, the common presentations when what they mean by indigestion is that some patients will actually tell me that they have some bit of heartburn, they get easy fullness. Sometimes when they eat, they had this feeling of feeling nauseous, vomited. So when this thing happens, right, the idea is to get themselves checked to see what exactly is going on. If these things continue to drag for long term, then we say that you should really get an upper endoscopy to be done. But if it's a short one, then perhaps maybe sometimes you might need to just get a doctor's consultation first to see whether is there indications to do so. Yeah. So that's yeah.
Okay, thanks for defining it for us. Now, Dr. Ramesh, usually at which stage can gastric cancer be operated on, and what about later stages?
Okay. Surgery is the main indication when it's either stage 1 or stage 2, right? Now, in stage 1, sometimes you may not need surgery. Very early cancers can be removed endoscopically.
Wow.
Through the scope, right, without surgery. Depends on which layers the tumor actually grow into. Now, if deeper layers, then, and if they're spread to the lymph nodes, then you will need surgery, right? So, but in stage 3, what we do is we get our help from our colleagues like Dr. Jensen. We downstage the tumor with chemotherapy first, and then we go for surgery.
Okay, that's interesting to note. And what are the recent advances in terms of the management of early gastric cancer?
So it's called, like what I mentioned just now, endoscopic treatment for very early gastric cancer, right? So it is a way of removing very tiny tumors through the endoscope, where they cut off the lining of the tumor, and then we send it for pathology. So these are tumors which have not gone beyond the stomach, meaning they have not gone to the lymph nodes. So that's where they are used, actually.
So for the early stage cancers basically gastric cancer, you can remove it endoscopically, and it's just a day surgery.
Probably just stay a day or two, that's all.
So I think that is very important and very good to know, but you must present at early stages. I think that's the key as well, and that can really save your life or whoever that is, predisposed to have stomach cancer at earlier ages. Now, the next question is, what are the key elements needed for surgeons and oncologists to collaborate to ensure perioperative chemotherapy is successful for the patient? I say the word perioperative, but I need either Dr. Jensen or Dr. Ramesh to define or explain it to us, because that is a new advancement in gastric cancer.
Yes, right, Mei Sze. So, perioperative, the definition of perioperative is that before that, speaking about gastric cancer, so in Malaysia, what I do see is that the numbers of patients that present are generally at the much later stage, more advanced stage. Approximately about a third of them presented with beyond the intervention of just doing a local mucosal surgery alone. So in this particular group of patients, right, so we consider that as considered as advanced disease, but they have not truly spread to distant part of the organs as yet. So when it comes to these circumstances, what this current practice we are doing is that we introduce the patients, those with a young, fit, with a good organ functions. We actually have this practice about giving a upfront chemotherapy, estimate about 2 months prior to the surgery, then followed by the subsequent another 2 months of chemotherapy. This is what we call as a perioperative chemo, followed by the surgery, then followed by the subsequent 2 months of chemotherapy again. So these sort of combined treatment modalities actually increases the survival for the patients, for those who are able to undergo the chemotherapy as well as the surgery. So perioperative here means that to be given prior to the surgery, then followed by surgery, then after with the chemo again. Yeah.
So for the layman out there, like myself, we would definitely want to know what was the previous type of treatment then.
Right. So I think perhaps Dr. Ramesh also can speak about the surgery types that previously it was done, and how it has changed over time.
Yeah. So I mean, many years ago we started something called as open surgery, right? It's a big scar in the tummy and to remove the tumors. So now we have progressed to more recent ways, which is called minimally invasive or keyhole surgery. So the advantages of this kind of surgery is the hospital stay is much shorter, recovery is much faster. So, but the key ingredient here is the quality of surgery for both has to be the same. It means you have to remove the tumor and clear all the lymph nodes. So that's where the key ingredient is very important.
And if I may to add on about this combined modality at a much later stage of the cancer treatment where surgery is still curable, there's also this thing whereby we actually need to get the patient specimens, tumor samples to be tested for something we call the microsatellite instability, because there is a small tiny subset of these patients that if they are proven to be positive, there's a potential that they are very immunoreactive to a treatment we call the immune checkpoint inhibitors. So this is something that is should be considered to be tested prior to the consideration of systemic chemotherapy followed by the surgery. So this is something, the practice that previously it was never been done, because as we get to learn more and more about this cancer treatment, we realize that there is such thing as targetable treatment that can be provided to the patient. Yeah.
I see. So previously, it was either just purely surgery, like an open surgery,
right,
without the chemotherapy. But now with perioperative, for those patients' conditions who can handle it, they can do chemotherapy and then the surgery and then chemotherapy again, and it's more effective.
Yes. So like what Mei Sze was saying, that for those who can handle it, so what I define this is that in order for someone to able to undergo this treatment, because this treatment is, I would not say it is rather easy, but for someone to able to undergo this treatment, he has to be fit, and he is also considered as a suitable candidate for surgery. In that situation, then this will be the best treatments for the patient.
How do you define fit?
Yeah, so the fitness here, the assessment is based on the patient's performance status, whether this patient, the age, any underlying comorbidities, that may sort of like have some sort of serious contraindications, for example, or in a way that might not be suitable to undergo such intensive treatments, or even from the point of surgery. Perhaps Dr. Ramesh is saying that they have to be able to pass the general anesthesia and all that. So if they are not fit to undergo that, then I would say that this treatment may not be the best for that particular patient.
Thanks, Dr. Jensen.
Yeah.
I think my next question is actually for you. Now, I mentioned earlier that research has shown that in Malaysia, many present at later stages, and I think you've echoed my thoughts as well. So what are the new hopes out there? I would like to think it's hopes, because, we want more advancement in treatment nowadays.
So I think my hope is always been that awareness is the most important thing. When you talk about a much rather later stage of cancers, then the treatments is rather much more difficult to manage. Yes, there are treatments, and as a matter of fact, there are a lot of new discoveries in terms of what can be offered to the patients. Nowadays, in the advanced stomach cancers, we are actually looking well into the molecular level. We look into certain molecules, any sort of targetable mutations that or targeted therapies that we can actually use it to combine. It's either as a monotherapy or as a combination with the chemotherapy in a much later advanced stage disease. Yeah. So the hope here is that I would say that the current progress in gastric cancers are much more positive, because that over the last decade, we do see there's a lot of new targetable drugs, new found medications that can actually be used in the treatment for stomach cancers. So I would say the outcome is good. The survival for the patients nowadays are actually doubled, in that sense. Yeah.
So just to kind of recap, there's the perioperative, which is fairly new, a type of surgery combination combined with chemotherapy, and then there's your conventional chemotherapy, and the newer ones are immunotherapy and the various types of targeted treatment, right?
Yeah.
Okay, so there's a lot more drugs and treatments available now, but you just need to be aware of it. But we know about it since we're talking about it. But how is the accessibility looking like here in Malaysia for patients out there?
Right. So, well, of course, there is challenges when it comes to the treatment part. So, as I mentioned that, in a much later advanced disease, when we wanted to look for the best treatments here, we actually look into the targeted therapies. So, prior to that, the patients will have to undergo a few more tests. This test is to look into which are the most appropriate targeted treatments. And of course, these targeted treatments, it doesn't come it come at a cost. Yeah. So when someone being tested it out, okay, and when we found certain molecules that can be targeted, for example, so if I may, I know that there's some of you out there probably will find that some of these terms are a bit more jargon, but I would say that things are looking for like HER2 positive, your MSI, your NTRK, your RAT, your BRAF. All these are the things that we actually look into when it comes to the much later advanced disease. So when we found this subset of patients, right, there is a specific treatments that can be given for these patients, and the outcomes is good. But the problem is that these treatments doesn't come at it comes at a cost, so basically the challenges will be that the affordability of the treatment is a challenge. So a lot of time I do see that patients do have some issues in terms of the financial part.
I see. Okay, so I think it's good to know that there are options available out there for a lot of people with gastric cancer or stomach cancer, or you're a survivor. It's just that the accessibility in Malaysia is low for the more advanced treatments. So I think we need to be aware of that as well. But the more important part, I think I want to drum it into many of you, is that if you present at early stages, you can do the most minor of surgeries, as Dr. Ramesh mentioned, which is through an endoscopy, you can remove the tumor.
Yeah.
That's all you need. So be aware, and if you have recurrent symptoms like indigestion, bloating, seek a gastrointestinal specialist. I think that's very important, or a gastroenterologist basically. And I think both doctors mentioned a lot of advancement nowadays. It's more of how we see it from a holistic perspective, and how the doctors can work together with the patient to access all these treatments that are available to us. So is there anything else you would like to share with the audience today before we jump into the questions from them?
I mean, for me, it's very simple. Early detection saves lives. Basically, if you have symptoms, go and see a doctor, get it detected, and you're safe.
Okay.
Yes. Same goes to me. I think awareness to know that there is such thing as gastric cancers, that is important. Educations, and even as we are speaking about gastric cancers, I do see that even in the aspect of other gastrointestinal cancer like colorectal cancers also, we still do see that there are people by and large that they still do not aware that there is such thing as to get themselves scoped at the age of 45. So I think that awareness is the key here. Second thing is that I'll say the treatments nowadays for stomach cancers has improved. As a matter of fact, we are talking right now, there are further advancement that's been done in terms of how to bring these new treatments forward to the much earlier stage. So imagine that this medication that used to be taken as a later on stage now has proven that it proves to be very efficacious, and they are now testing out in the much earlier stage, and hopefully to bring the best outcomes for the patient.
Okay, so thanks a lot for the take home for the audience today. I would like to ask actually whether you guys have questions. I should have actually asked earlier and reminded you guys, so please put in your questions now. We're going to give you a minute to think of the questions that you have and that we've discussed, so that you can come in and ask the questions that you want. I think some of you are patients of either one of these doctors, and they want to hear from you, I want to hear from you. What are those burning questions you have about gastric cancer or stomach cancer. We want to discuss them here and we want to answer them. So put in your questions now. We'll give you a minute or so to put in your questions. I think I see that I just saw some of the comments. The line was breaking, and some of you there may be a lag. So we'll give you some time to put in your questions because we want to hear from you before we wrap up the session for tonight. So, I mean, it's very interesting to know actually from the both of you about, I think perioperative, the word itself is very it's not something that we hear of often. And also before this, a lot of people talk about, oh, should I do chemotherapy before the surgery or should I do chemotherapy after the surgery? So now with this new form of treatment, they do chemotherapy before and after the surgery.
Yeah, if I may add that, speaking about the perioperative treatments, I think one of the key elements about when someone that is being diagnosed with stomach cancers and what they actually really need is that, to have the doctors to able to come together, because the treatment of gastric cancers, it is a multi-modal approach, which means that, it's not a standalone sort of the disease that can be handled by just one person. If I was to say that, what it means by multimodal approach here is that it requires like specialties like the surgeons, it's an upper GI surgeon itself like Dr. Ramesh. Then you have an oncologist, a radiation oncologist. At some point you may also need specialists like pathologists to able to provide a much detailed analysis of the tumor samples and all that. And once you do also need specialties, for example, like cancer genetic professionals and also nutritionists as well. Not to forget that when someone had a stomach being taken out, that also means that they have lost one of the part of the digestive organs. So the nutritionist, dietitian here also plays a very important role. So my message here is that when you have a diagnosis as such, right, it's always good that if you're able to find a team of doctors that are able to come together to bring the best outcomes for your disease. So that is one of the important things about this perioperative multimodal approach.
I think that's not really easy in Malaysia because the oncologist keeps pushing you to look for another specialist. So I think this is for the doctors to take note who are tuning in. We need more multidisciplinary teams here in Malaysia, especially to care or to treat a disease like cancer. Now, I see that I think some of you are putting your questions. Continue putting in your questions. We'll filter them and pick them up so we can answer them now. One of the question is, after all the surgery and chemo, what kind can one do to monitor to make sure the cancer doesn't come back? Is recurrence common with stomach cancers? Thanks, Lisha, for your question.
Yes,
okay. If we talk about recurrence, what we do as surgeons, we do a surveillance after surgery, right? So once they have completed their chemo, then they go follow up with the surgeon and the oncologist. So we do certain blood tests like tumor markers, and from our point of view, we do investigations like endoscopies and CT scans. So we do that regularly, 6 months, 1 yearly, and usually up to 5 years. So 5 years is the golden period, what we say, for most types of cancer. So that's how we surveil these patients actually. And they also see the oncologist to get their tumor markers done and other forms of investigation.
Yeah. So just to add on is that in my day-to-day practice, someone that is diagnosed with gastric cancer, so what I would do is that I will check on the patient. Is the patients they do present with raised tumor markers. So for those people that had the presentation of raised tumor markers, it's actually a good way to follow up on the patient. But of course, tumor markers are not that specific. So along the way also during the first 2 years, I would say that the follow-ups is really, really crucial, because despite all the surgeries, the chemotherapy, we know that the relapse rate is actually high. So what we do is that every 3 to 4 months follow-ups, the doctors will check, examine the patients, perform blood tests, like I said, the tumor markers, doing a scope like what Dr. Ramesh says, and also imaging as well. So these imaging scans will help to detect early if there's early recurrence in that sense. Some doctors, oncologists, they may also do consider certain things, for example, like getting the tumor tissue samples that was being removed previously, as well as a blood sample to look for something we call it as the circulating tumor DNAs or minimal residual disease. Because there are certain cancers, for example, like in gastric, colon cancers, they have this tendency, some may have tendency to shed these tumor cells into the bloodstream. So some oncologists, they may actually, speak to the patients regarding about this particular test when all other tests, for example, markers tend to be normal, and the imagings may not actually able to pick up a very early relapse recurrence and all that. So in that particular situations, perhaps an additional testing that can help guide the doctors in terms of monitoring the patient is also very helpful. So the first 2 years, like Dr. Ramesh said, is the most crucial one. And as 2 years has passed, let's say everything goes well with the blood tests, clinical examinations, imagings, scopes, then the subsequent third, fourth, fifth year, then we say that the frequency of follow-ups tend to be a little bit longer, but still the patient needs to be followed up until the fifth year. Now, we don't really stop at the fifth year, even though we said that the chance of cancer relapse after 5 years is way much lower. We still do see the patients because there's still a very small subset of patients that actually do tend to relapse at that point of time. So it's all really about having the patients to follow closely with the doctors, and it's not just about the recurrence, but also to follow with doctors about what are the long-term side effects that they have gone through. For example, like how is their nutrition wise, how is their vitamins and body electrolytes and all that after having the stomach removed. And for those who had chemotherapy, they might be monitored about how is their performance, the energy levels in the long term. And of course, the other thing also for those who had undergone radiations, they will also need to be followed up to know about what are the long term, toxicities that they do have. Yeah.
Thanks a lot for answering that question. Thanks, Disha. I think Dr. Jensen nicely answered that recurrence for stomach cancers is actually very high. So if you or your family member or someone close to you has it, you need to take note of that and to monitor very closely. And the next question is, what are the risk factors in stomach cancers? Are there certain group of people who are more prone to stomach cancers?
So actually, something called as a carcinogen is something which the term carcinogen, right? And one of these thing is a bacteria called a Helicobacter. Now it's very high in many countries around the South Asian region, right? Japan has the highest rate of gastric cancer. Now Helicobacter in Malaysia, I think the highest is among the Chinese, second Indians, and the lowest the Malays. So the other thing besides Helicobacter is the type of food we eat, pickled food, then other factors like smoking, alcohol. So the general risk factors, but basically for stomach cancer is Helicobacter and the types of food which we eat.
So H. pylori and diet. So diet is actually very important to reduce the risk for stomach cancers. And I think this question is a common one. One of the question is, so gastric and indigestion are symptoms? Yes, it is, right?
Yeah, it's a general term, gastric. When somebody says I have gastric pain, it means indigestion. Yeah.
Okay, so I think one last question here is, does diet play a role in the development of stomach cancer? I think Dr. Ramesh, you mentioned that diet does play a role in the development of stomach cancer. So, I mean, we all know we should be avoiding processed food,
correct,
alcohol. Is there anything else we should avoid? Grilled, I mean, like fried or?
Ultra processed food, basically pickled food, like I mentioned earlier.
Pickled food.
Yeah, pickled food. Now, certain foods, which few studies have been done in UM and showed that turmeric may help people who eat turmeric, right?
I think I read about this.
Some reduced incidences of that, but basically it's this type of very alcohol and pickled food and this kind of food actually.
So I think my last question actually from me, I love kimchi.
Right.
So that's pickled. Is that
No, yeah, we're talking about really, really long term and lots of
is there
high
a high rate
consumption.
of
No.
in Korea?
In Korea and Japan, very high gastric cancer.
Okay,
Very
wow.
high gastric cancer.
If I may add, actually, if you look at the world, the distribution of gastric cancers, right, it's actually rather much more common in the Eastern Asia, the Eastern Europe, but less common in the North America or the African people. So I think it's partly because of the environments, the exposure, the food that they take, the genetics itself. I believe that it plays a role as well. So that's why that when we revisit back the part when we talk about screenings, right? Because in the Eastern Asia, for example, like Japan, gastric cancer is just so prevalent. As a matter of fact, it's actually number 2 in top of their list, and their mortality from gastric cancer is the 3rd. And because of that, they actually have a very good screening programs for the country. So to have a good screening program, this is also it also depends on how common is the cancers that is happening in that country. So in Japan, they actually do a regular endoscopy as early as the age of 40. They used to do some imagings, but nowadays I think they are standardizing it into the endoscopy to screen through the Japanese population people. Yeah.
That's interesting. So that's a risk factor, and you would say one of the common causes, someone did ask about causes of stomach cancer, would be definitely the food and genetics.
Yes.
Yeah.
Okay.
So speaking about a little bit about genetics, I would say that there's small subset of population of gastric cancers are genetic inherited, which is we're looking at about 3 to 5%. So this group of patients, if happen to have a strong family histories from the interview between the doctors and the patients, right? Then this is the part whereby that the doctors will, if necessary, to make the recommendations to bring in the cancer genetic professionals to further access the family histories in order to find out whether the family truly have this genetic cancer inheritance.
I think that is definitely a topic we need to discuss for one of the episodes. I will have that discussion soon. So thank you so much, Dr. Ramesh and Dr. Jensen, for joining today's episode, which is called A New Hope for Gastric Cancer. So to all of you who are celebrating Chinese New Year, Happy Chinese New Year! 恭喜發財, 恭喜發財. Enjoy your break, and to the rest of you, have a restful holiday. We'll see you after that on February 20th for the next session of Talking Life with Mei Sze. We cannot wait to see you, and of course, once again, happy holidays and enjoy all of the Chinese New Year festivities. Thank you and bye. See you soon.